Thanks, Beth. Can you hear me okay?
Yes, sound great. Thanks.
So on behalf of Bo and myself, who are co-chairs of the Research Working Group, we're really excited to be part of ACIH, sharing this wonderful work by Nadine Ijaz and her co-author team. Whole systems research has certainly been on the forefront of people's tongues, and it is a tremendously exciting area of research, and it's wonderful to hear from some of the experts in the field like Nadine, who are really leading this pack. So it's a real honor to introduce her. Nadine is a colleague through INCAM, a fellow Canadian, and really pleased to hear from her today. So Nadine is a PhD and postdoctoral research fellow at the University of Toronto's Leslie Dan Faculty of Pharmacy. Who's also been a clinician educator in the integrative health field over the last 20 years. She currently conducts research related to health policy, research methods, and education in these fields. She also happens to be a medical herbalist with many years of clinical and teaching experience at colleges of Western herbal medicine, Chinese medicine, and integrative nutrition. Dr. Ijaz was previously staff nutritionist at Inspire Health, which was Canada's largest integrative oncology center and one of the groundbreakers in this area. She was recently awarded 2 faculty teaching awards at McMaster University, and over the years has worked for non-governmental organizations like Doctors Without Borders, Islamic Relief Canada, and the Arms Race and Environmental Youth Alliance. And recently, and very relevant to our webinar today, Dr. Ijaz led a team that included Research Working Group member Jennifer Ryu and past ACIH Executive Director John Weeks to publish a paper entitled Whole Systems Research Methods in Healthcare, a scoping review. This is open access and available through the Journal of Alternative and Complementary Medicine. Please give a warm welcome, or potentially silent welcome, to Nadine Ijaz.
Thanks so much. Thank you so much. All right, Nadine, I'm on board to change your slides as you would like them.
Okay, perfect. Well, hello everyone. Can you hear me all right?
Yes, thank you.
Okay, so it's great to have everyone on the call, and thanks so much to Kieran for the kind introduction. I'd also like to thank Beth and the collaborative for the invitation to lead this webinar on whole systems research, which is a topic that I hope you will be as excited about as am I. So I would like to talk about a lot of practical things research related today, but I would like to start with a philosophical point about research in 2 parts. So the first part of this point is that generally speaking, research should generally strive to be rigorous and transparent in their work. The second part, which I think is perhaps more relevant or most relevant also to our topic today, is that research is never a neutral undertaking. Now, what I mean by this second point is that the questions that researchers ask and the methods that we use in any research project will always reflect a particular stance about what we consider to be true or important in the world. So quantitative researchers often call this bias and characterize it as a negative thing rather than as a simple fact about research on the whole, whereas qualitative researchers tend to call this positionality, and there's a lot of debate about these issues that I'm happy to discuss later on. But this basic idea that good research should be rigorous and transparent, but is never really neutral, is at the heart of whole systems research, as we'll discuss today. I'd also like to observe that research, and clinical research in particular, is a kind of a political currency. So what this means is that good quality clinical research is a necessary, although not sufficient, condition for transforming our health systems to be more inclusive of traditional complementary and integrative health and medicine, or TCIM, approaches. Now, as most of you likely know, TCIM approaches are typically tend towards being holistic and preventive in character, are often tailored to the individual patient, and often involve multiple modes of treatment at the same time. And in some fields like Ayurveda and Chinese medicine also involve non-biomedical or non-Western medical diagnostic paradigms. Now, whole systems research, as we'll be discussing today, refers to a particular clinical research approach that seeks or aims to accurately evaluate these types of TCIM interventions as practiced in the real world, and as a result, sometimes requires particular research methodologies to do this. Okay, next slide, please. Okay, so in today's webinar, I'll be talking about the results of a recent scoping review about whole systems research, which you can see on the right of the slide there. Now, we'll have a chance to talk in detail about what makes this type of research both important and unique. But as a way in, I'd like to talk a little bit by way of introduction about my own involvement with this topic. Now, what I want to state from the outset is that I am primarily a health policy researcher. Unlike two of my co-authors on the scoping review, Drs. Jennifer Ryu and Charles Elder, I am not a researcher who actually conducts whole systems clinical trials, but rather somebody who carefully reads and interprets these kinds of trials in my work. Another way that I interact with clinical research is as an educator. And over the years, I've taught courses on research methods to Chinese medicine and acupuncture, Western herbal medicine, and integrative nutrition students. And in my experience doing this, something that typically comes up among students on the first day of our research-related classes is a kind of skepticism about the use of the classical randomized placebo-controlled trial in their particular clinical fields. Now, to be fair, and as I'll explain as we go on, I often tell students that I share many of their concerns about the poor representation of their clinical fields in a lot of published research. And then, to break the tension and get them engaged, I also tell them about whole systems research. So the pictures that you see on the slide here are actually from my own former herbal medicine clinic on Vancouver Island. And in line with my training in East Asian medicine, you can see that I'm using a traditional pulse diagnosis with a patient. I'm also compounding an individualized herbal formula for her that I'll likely change the next time I see her as her body changes in response to the medicine. And while I'm of course alert to any particular or potential drug interactions that are documented in the scientific literature, you can see on the top left that I'm relying on historical texts and teachings as, quote, evidence to inform my own therapeutic strategies. Now, something I used to think about a lot in practice, which is relevant to our discussion today, is trying to imagine conducting a randomized placebo-controlled trial of my own clinical practice or of patients in my own practice. So we could imagine 50 patients, let's say, with the same biomedical diagnosis, let's say diabetes, and these patients might get, say, 50 unique herbal formulations based on their individual constitution and imbalance that they would present with. I might change those medicines from week to week to respond to their changing needs. I might make nutrition and lifestyle recommendations for each of those people, which again would vary somewhat according to the person's situation. And depending on the individual's symptom picture, I might also offer acupressure treatments, which is also something that's part of my treatment toolkit. Now, from a conventional clinical research perspective, this might sound like a nightmare. So why a nightmare? Now, if we consider the design of a classical randomized control trial, this starts to make sense because those types of trials, historically anyway, although this is beginning to change, are really designed to evaluate a single intervention that stays stable over the course of a particular period of time. And here we are with a situation where every patient is getting something different, a combination of different things, and these treatments keep changing. What are we going to measure and how? And how can the results of such a study be even remotely meaningful? Also, we might sort of try to create a credible herbal placebo for a control group, but how could we create an effective placebo for things like nutrition and lifestyle that involve behavioral change, or acupressure, which involves touch? These are certainly challenges if we're married to the classical randomized control trial as the gold standard of what constitutes good clinical evidence. But the big question is, for TCIM practitioners who are not necessarily working in ways that only involve a single agent and one single diagnosis, how can we enter into producing evidence that evaluates what we're doing so that we can enter into the bigger policy conversation about what belongs in mainstream health systems? So next slide, please. So I'd like to spend a couple of minutes unpacking the table on this slide, which basically summarizes the methodological problems that have created the need for whole systems research strategies, which a number of researchers have really taken on over the last 20 years or so, as we detail in the scoping review. this is really a summary, and it's a little oversimplified, which I'll try to convey as I walk us through it. And if you'd like to know a little more about any of these particular points, you'll see that there's a little bit of detail and referencing of several dozen studies where these issues are detailed. So I'm going to start from the bottom up, although I may move around a little bit as we go on. So the first sort of question when we're talking about designing a clinical research study is really, what is the aim of the study? And I've set this up as a binary, although this is not always necessarily going to be polarized in this way between biomedical trials and TCIM interventions. It's a bit of a false binary, but for now, let's work with it. So as you can see on the bottom left, the classical aims of a randomized, placebo-controlled randomized control trial, which is really considered the gold standard of clinical trial evidence within the biomedical profession, it aims to explain the effects of particular treatments and validate best practices through studies that aim to really demonstrate or work towards demonstrating causation. Right? So by comparing, the idea is by isolating the effects of a single intervention and comparing it to a placebo control or an inert placebo control, the idea is that it is strong research design for really isolating the effects of a particular intervention and demonstrating under ideal conditions whether this intervention actually has the effect that's being that's sought after. Now, this is really somewhat different often when we're talking about interventions in the TCIM field. Now, we can consider this from a few different perspectives. One is that in biomedicine, the RCT design, or the classic RCT design, is really well designed if we're talking about evaluating pharmaceutical agents, right, which do need to undergo trialing for safety and efficacy before they hit the market. Now, conversely, when we're talking about TCIM interventions, these are often interventions that are already in practice for long periods of time, sometimes centuries or millennia before quote-unquote evidence or biomedical evidence for them is demonstrated. So the trajectory from evidence to practice or practice to evidence is really different, right? So and so often with respect to research in the TCIM field, the aim is not necessarily to explain the effects, but rather to evaluate therapies that are already in practice, but evaluate whether they warrant further integration into the mainstream health system. And so the question itself is different, right? And that's why I raised from the beginning that no research method is neutral. And so the classical RCT design is really well suited to answering a particular series of questions, but that method is not necessarily ideally suited to the types of interventions and the study aims that are at play when we're talking about traditional complementary and integrative medicine. And so you can see on the right-hand side these various issues that I raised a moment ago. From the top down, often a patient that goes to see a TCIM practitioner, I know there are various paradigms, but often the patient may have multiple different health concerns going on at the same time. The treatments may be complex or multimodal. So, for example, someone may be receiving acupuncture, herbal medicine, and diet and lifestyle recommendations all at the same time. As I mentioned earlier, as compared to being a standardized or static intervention, interventions are often tailored and change over time. Another issue that has come up historically in research around traditional complementary and integrative medicine is the issue of what counts as evidence, right? What counts as an outcome in a trial that demonstrates effectiveness or efficacy, right? And so conventionally or historically, there's this use of objective biomarkers, so things like blood work or other biological markers that can be tangibly measured. Whereas often in clinical practice, TCIM practitioners are not necessarily using those types of biomarkers, although in some cases they are, such as in naturopathic medicine, that may be the case. But there may be much more subjective or practitioner-based assessment of a range of holistic sort of markers that the patient presents with. So just to give this sense of the methodological dissonance that may come up when we're trying to study TCIM interventions using the classical RCT method. And as I mentioned a moment ago, the issue of placebo often comes up. There's a substantial literature discussing the challenges in designing placebo controls for things like acupuncture or chiropractic. And the problem is that even though some sham or placebo control designs for those types of interventions may not be as active as the active intervention itself, they're not themselves inert either. And so this calls into question how effective these things are as placebos. Okay, so can we move on to the next slide, please? So I'm presenting here on the slide different models of evidence that have been variously discussed in the literature. The one here on the far left with the colors is really the hierarchy of evidence as generally accepted as the norm in evidence-based medicine today. And what you see at the very top is the systematic review, and that usually refers to systematic reviews of randomized controlled trials that have a placebo control. And as you move down the hierarchy, there are other study designs that are considered lesser in terms of their ability to demonstrate causation. So they're considered, in this model anyway, considered to be studies of a lesser quality, and you move all the way down to observational, sort of non-randomized controlled trials, so trials with a control group that aren't randomized, to observational studies with comparison groups and other types of observational studies, all the way down to case studies, case reports, and expert opinion, which in this model is considered sort of the least credible form of evidence. Now here on the right, towards the middle and the right, you see two different models. These are not the only sort of alternate models that have been written about in the literature, but they do come from researchers working in the TCIM field. You have Jonas's evidence house, and then the circular model, which was produced by a team of TCIM researchers. Again, these are somewhat older, but the basic idea in each of these models is that rather than positioning one type of evidence, like the placebo-controlled RCT at the top of a hierarchy, why not consider that different research methods may be appropriate under different circumstances for different purposes. And so that under one circumstance, a totally different research method may be the superior method. So for example, in terms of making public health decisions or clinical decisions at the everyday level, health services research or epidemiological research may be much more relevant than, say, placebo-controlled RCT. Right, and so really this suggestion that a range of methods be considered for their various utility. Now, I did want to mention at this point that critiques of this evidence hierarchy, the multicolored model on the left, do not just come from the TCIM community. There are people from within biomedicine, conventional medicine that have had these critiques, shared these critiques as well. For example, there are many interventions, conventional biomedical interventions, that really are difficult to study using a classical randomized control trial, such as a surgery. It wouldn't necessarily be ethical to randomize people to a placebo group if they really do need a surgery urgently, or in the field of psychiatry, let's say, difficult to do clinical trials that create a placebo for psychotherapy, right? So these issues have been raised outside the community. And in response, over the last 20 years, there have been shifts in the research community that aren't necessarily reflected in that research hierarchy, but there has definitely been a movement towards greater acceptance of things like pragmatic clinical trials, which instead of using a placebo control are a comparative effectiveness model where you put two different interventions head-to-head to compare their effects in the real world. There has also been greater acceptance of research methods that address complex interventions that involve more than one mode of treatment at the same time, so the acupuncture plus herbal medicine type of approach. And the Medical Research Council out of the United Kingdom has a fairly elaborate sort of detailed model or guide to designing trials in this area. So just to be clear that this field has been evolving over the last 2 decades, not just in the TCIM field, but also in conventional medicine. Okay, next slide, please. So I'd like to move over to this principle that we're calling model validity, which is really key when we're talking about whole systems research. Now, model validity really refers to what we've been talking about already today, which is a good fit between the research design, the studied intervention, and the underlying paradigm. And as we go through our slides today, I will be talking more about model validity and how it's relevant in designing whole systems research studies. Okay, next slide. So just to take a moment to tell you a little bit about the scoping review that was on the slide a moment ago, in which I think Kieran mentioned is available in open access. Now, the purpose of this scoping review is really to map the range of clinical research features pertaining to model validity that had been elaborated in the TCIM community over the last 20 years or so. So there were sort of in the 2000s, late 90s and 2000s, a fairly large number of theoretical papers that were published critiquing the conventional research norms and explaining really in detail how these research methods didn't necessarily always fit TCIM modes of treatment. But until now, there hadn't really been a retrospective review of what people had done in this field to respond to those concerns. And so the aim of the study was really to see what's happened in whole systems research. What have people done? What kind of study designs have they innovated? How have they handled design of their interventions? How have they, what outcome measures have they used in their studies to document the types of treatments that are typical in this field? And so to undertake this review, we basically conducted a search to find a number of what we ended up finding out or locating 41 exemplars, and that doesn't mean these were the only whole systems research studies in the field. It means that we identified these as exemplary in the sense that they exemplified particular methodological features. And our goal was really to map the range of clinical research features so that people who are wanting to conduct research in this way, such that their studies really reflected the model validity principle, would have models or examples of how they could go about doing this. And so we identified these studies through a combination of an expert consultation process with people who were already working in the field, and also through some supplemental literature searches, which you can read about more in the paper. And our inclusion criteria required that any study that was going to be considered for inclusion would be a peer-reviewed, completed clinical research study involving some type of traditional complementary and integrative medicine intervention, and that these studies or the interventions in these studies really needed to include at least 2 of the following features. They were either complex or multimodal interventions. They involved individualized care. They had a health or preventive or behavioral focus. They involved patients who had more than one disease condition, so multimorbid patients, and another possibility was that the studies would include dual diagnosis. So dual diagnosis would mean both a biomedical, Western medical diagnosis and a diagnosis from within another clinical paradigm, such as Chinese medicine or Ayurveda or anthroposophic medicine, for example. Okay, next slide, please. So as I mentioned, we did locate, we decided on 41 clinical exemplars. Some of these studies had multiple associated publications. and some just had one associated publication. The studies were very diverse. You can see that they represented a wide range of TCIM disciplines, and this was deliberate. We were wanting to ensure that we represented a cross-section of different clinical approaches to see whether there were particular methods that might be useful in some versus others. Study sizes were quite distinct. We're saying here 1,000 to 3,000 patients, and that's because we did include one individual case report, and then we had sort of large 3,000 patient observational studies. So they were very diverse in size, also diverse in duration. There was one study that was only 1 day long. It involved an intervention in a hospital to relieve pre-operative anxiety, and then there were studies that lasted several years with multiple follow-ups, often for chronic conditions. And you can see that there were a wide range of areas of clinical focus that were addressed across these studies, ranging from acute and chronic illness to mental health considerations. There were also some studies that were very unusual in the sense that they didn't specifically focus on a particular, quote, disease name, but rather on working with patients who had medically unexplained symptoms. Some studies were specifically focused on quality of life, say among oncology patients, and others were more preventively focused. So as you can see, there was quite a lot of diversity represented across these studies, but they were all really clinical studies in some form or another. Okay, next slide. Now, what we have here is basically a summary of the most common study designs that we identified across the 41 exemplars. And I'll just walk through this with you here. So as you can see on the left, most of the studies that we evaluated were comparative effectiveness trials, right? So that means that, again, that instead of using a placebo control, these trials really tested a particular TCIM whole systems intervention versus usual conventional biomedical care. Sometimes these were studies that involved what I'd call a usual care plus design, where, you might consider them an integrative design, where, for example, a patient or patients would be receiving conventional care, and in addition, they would receive a TCIM intervention, say naturopathic medicine, and that would be compared to usual care alone. Some studies were factorial designs where, given the example there of an acupuncture trial versus the same acupuncture intervention plus herbal medicine. Some studies included mixed methods that could be qualitative methods such as patient surveys or interviews. Some included economic evaluations. The studies varied in terms of their allocation, so how patients were assigned to their treatment group was often randomized. So they were often randomized controlled trials that were not placebo controlled, right? But some of the studies involved more pragmatic allocation mechanisms where a patient would have the choice to determine what treatment they would prefer to receive. And then there were some studies that were allocated via matched pairs design, so where there would be an active treatment group and then a comparator would be elaborated with reference to electronic medical records, the EMR that you see on the slide there. Now, across these designs, these pragmatic comparative effectiveness designs, there were very rarely use of double blinding, often because the interventions included behavioral components, so it's very difficult to blind somebody if they're receiving, say, a nutritional intervention. Usually people are quite aware of what they're eating. And again, rather than the sham or placebo controls, most of these studies, as is typical in a pragmatic trial, involved active controls. And you can see there on the figure to the right that, again, usual care comparators were most common. Open label studies were the norm, so very little blinding going on at the level of the practitioner and the patient, although some studies did involve blinded technicians. Randomized assignment was the norm, but not overwhelmingly so. So about 2/3 of the studies, and you know, a reasonable number here, slightly less than 40% used some form of mixed methods in the study. Having said that, as we see towards the bottom, there were quite a number of non-controlled trials used that we highlight in the review because they seem to really exemplify the whole systems design principles. And these included pre-post observational studies, so that would be a study where a particular group of patients would be they would have particular outcomes measured before and after receiving a particular intervention, but not with a comparator group. In some cases, these studies were quite large, such as the 3,000 patient study that I mentioned earlier in Germany of anthroposophical medicine being used for chronic disease. And this is quite important because there's an increasing literature suggesting that large observational studies often quite accurately anticipate the results of randomized controlled trials. There were also some N of 1 series trials. Now, for those of you who may not be familiar with the N of 1 design, it's a design where a person becomes their own control. So, for example, someone will receive a treatment and then a particular intervention for a period of time, and then they'll go into a period of receiving a placebo of that intervention for another period of time, sort of back and forth, A, B, for repeated series, and they're usually blinded to what treatment they're receiving, so the outcomes can be measured in relation to the treatment that they're receiving. And the N of 1 series designs involve several N of 1 trials, and the results can get pooled. And then there were also some retrospective designs that we reviewed where researchers were looking back into clinical records, usually a significant number of them over multiple years in some cases, or a shorter period of time for various chronic conditions or things like fertility. And so there were, as you can see, a fairly large range of designs, and we're not necessarily privileging one over the other, but our goal was to sort of map out how within these various designs the principle of model validity could be expressed. Okay, next slide, please. So again, a fair bit of variation in how the interventions in these studies were conceptualized. Now, if you look at the figure on the top left, you'll see that pretty much all or virtually all of the interventions that were being evaluated across these studies were multimorbid in some sense. Now, this is really, I think, quite interesting. Multimorbid meaning that they were not necessarily focused on one single outcome. Right, so it wasn't necessarily that heart disease was the only sort of clinical condition being evaluated in terms of the impact of the therapy, but say mental health was concurrently being measured as an outcome. Also, patients who were included in these trials were not required to only have a single condition. It was okay if they were showing up with multiple conditions at the same time. Also, the vast majority of the trials involved complex interventions. That means multimodal, or the acupuncture plus herbal medicine type design. Individualized interventions were the norm rather than not in these trials. A large number of them, consistent with TCAM practice, involved behavioral interventions, so interventions that diet, lifestyle, exercise, things like this, that ask patients to make their own changes. And about half of the trials we evaluated involved some form of dual diagnosis, and a few less some multidisciplinary or team care. And as you can see on the bottom right, what we've done is really mapped out study by study the individual features of each trial that we've looked at, so that if somebody is wanting to design a study, they can look at these, look at our tables and say, okay, my particular intervention has these features. Can I go back and look at another study that has worked with something like this? And so we might model our study after it in some way. Now, as I mentioned earlier, some of the studies that we evaluated had multiple associated publications, and I've just put one up on the top right there, which I thought was quite interesting because it involves the development of a protocol. Now, I'm just going to introduce this word manualized for those who aren't familiar with what a manualized protocol is. Manualized protocol really refers to a kind of standardized or semi-standardized protocol for treatment. And it's a way of mapping out treatment that could be individualized but systematically individualized, right? So for example, say there was, people were coming in for massage therapy for osteoarthritis. There are particular parameters around which the clinicians in the study could design their treatments, and the clinicians who are as part of the study are asked to stay within those parameters. And so in a sense, it is a standardized protocol, which is standard in conventional randomized controlled trials, but it leaves a little bit of wiggle room for the clinician to individualize according to the needs of the patient. So this was something that we saw in a number of studies. Okay, next slide, please. And this is really leads us quite nicely into this slide here, where we've mapped out this individualization spectrum, just to give this idea that there are different ways of individualizing treatment and that these can be addressed differently within the design of a particular study. So on the far left, we have general standardization, which is really conventional in a biomedical placebo-controlled RCT, where the treatment that every patient receives in the study is exactly the same. And on the far right, we have unconstrained individualization, where say a patient's going to see naturopaths or other clinicians for care might each receive treatment that is individually tailored or individualized to their particular situation, but the clinician is given absolutely no constraints as long as they're working within their statutory scope. Now here towards the middle, we have this sort of middle ground that I was just describing, manualization with tailoring, which in a sense reflects more so the historical patterns of practice that you might see in a system such as Chinese medicine or Ayurveda, which are pattern-based, that involve pattern-based diagnoses, right? And so there are often historically protocols that are approximate protocols that are outlined for clinical practice within which the individual clinician might then sort of alter the treatment a little bit with moving the acupoints a little bit or selecting additional points or different herbs for the individual patient, but basically there's a semi-standard protocol. And recognizing here that also some interventions have components of they may have some parts of their intervention may be tailored where other portions may also be standardized. For example, some of the studies we evaluated, all patients were receiving the same type of supplement, but some received individualized nutrition and lifestyle advice. Okay, so next slide, please. So I'd like to touch a little bit on dual diagnosis and how this was handled across the studies we evaluated. Now, across the 41 exemplars, we deliberately overrepresented Ayurvedic and Chinese medicine studies because of the issue of non-biomedical diagnosis, which is so key in studying interventions in this field. So there were there were a number of different approaches that people took in designing their studies in this way. But as you can see here in the middle of the slide, this is an example of sort of a manualized treatment protocol where on the left you'll see the syndrome diagnosis or the pattern, the Chinese medicine pattern that a patient may be identified to have by the clinician, and then the points, the acupuncture points and herbal formulas that might be considered as a base. So these are really the parameters within which a clinician who's participating in the study might decide to treat, and those are pre-identified or laid out in advance, and the clinician then has some flexibility to determine within these parameters what treatment options they might might like to use. And what this allows for is the fact that many patients with the same biomedical diagnosis might have quite different diagnoses from within a Chinese medicine or Ayurvedic perspective, and that in the real world, practitioners from within those particular disciplines are treating each patient as having a different condition and not just according to their biomedical diagnosis. And this was seen in a number of studies, and some of these studies also mapped out in their results how many patients had particular Chinese medicine patterns or Ayurvedic patterns, for example. And so this was addressed right in the design. Next slide, please. Now, another issue that was of interest to us in doing the review had to do with the types of outcome measures that researchers used to try to evaluate outcomes, patient outcomes. And as you can see in the sort of checkerboard table here, the third column there is objective outcome measures. And you can see that although some studies did use objective biomarkers, so those in black, the little black squares, as their primary study outcomes, so things like blood work or tangible measures of health events like a live birth in a fertility study or a cardiac event in a cardiovascular study, the vast majority of outcome measures in the studies that we evaluated were subjective or involved patient-reported outcomes. So this is something that, of course, in conventional quantitative focused biomedical research communities may be considered somewhat less, quote, rigorous than the exclusive or primary use of objective outcome measures. This use of the subjective measures really does reflect to a substantial degree the kinds of things that clinicians are really measuring in their clinical practice with their patients. Some studies were also using patient-generated outcomes where the individual patient decides what it is that they themselves identify as important in their health, and then that gets tracked over time. And another really key point, as you can see on the far left of the checkerboard, is that a significant number or the majority really, of the studies involved measurement of outcomes that was not just at the beginning and at the end, but also had some form of intermittent follow-up to track outcomes on an ongoing basis rather than just before and after, which again reflects to a greater degree what really does go on in clinical practice. So next slide. So I know we're getting a little short on time, so I'd like to try to pull this together and talk about moving forward. Part of the review is really an analysis of where the field has come to this point. And I think one of the really interesting things is that although there are distinct methods being used in whole systems research, by and large, the methods that we're seeing researchers use really do resemble in some form or another conventional biomedical research methods with minor modifications. Another point that we noted is that most of the outcome measures being used in these trials were validated outcome measures that had been developed in biomedical environments. So whether those were quality of life measures or osteoarthritis pain measures, they were measures that in the context of a systematic review would be comparable to what you'd see in a non-TCIM study, which really in one sense is advantageous because it allows for sort of direct comparison of outcomes. However, one of the issues that we've addressed or written about in the review is that there may now be enough steam in this movement that it's time to really think about whether we should be developing paradigm-specific outcome measures that evaluate from the perspective of the paradigm that the intervention comes out of what the clinical outcomes are. So for example, if somebody goes to see an Ayurvedic practitioner, the practitioner is measuring outcomes in Ayurvedic terms. They're not necessarily using only biomedical thinking to evaluate what is happening. They'll be using pulse diagnosis, tongue diagnosis, and various Ayurvedic concepts to determine how successful the treatment is. And this is something that to date is not significantly reflected in the whole systems research. And part of the problem with this is that often there may be outcomes that someone may be witnessing or observing from within a particular paradigm that are ignored or not evident because they're not named in the biomedical outcome measures. Now, my co-author, Jennifer Ryu, her paper is featured here on the left in the slide. She's been, I think, really a leader in thinking about some of these particular issues in terms of how paradigm-specific outcomes can be measured, and she has a paper also in the same special issue that I think models how this may be undertaken, and I would urge you to look at her work because I think it's really outstanding and sets the tone for one area where we can really move forward in this field. Okay, next slide. Now, another question is, how does whole system research really fit into broader research schemes? And I addressed this briefly a moment ago by talking about how the outcome measures that whole systems researchers have been using until now really allow whole systems research studies to be included in systematic reviews. However, there are methodological problems that remain, and one of those issues has to do with the way in which strength of evidence is conceptualized for things like lifestyle trials, right? So, for example, historically, it's very difficult to track over many years, for example, the effects of particular diets or of dietary or lifestyle approaches because there are so many confounders and those things can't be easily studied in a randomized control trial model. And so here on the left we have a very recent publication by a group of researchers who are arguing, similarly to what's been argued in the whole systems research world, that the classical RCT really shouldn't necessarily be considered the only credible or the most credible form of evidence. And they've developed a model for evaluating sort of more lifestyle-related trials within the context of a systematic review. So I think this is definitely an area where the TCIM world is starting to intersect with the more conventional world, and we're developing tools to bring this type of research more to the fore. Okay, next slide, please. So just in conclusion, I know in discussion with some people, this question has come up of whether whole systems research is really a distinctive field of its own because it has so many features in common with pragmatic or comparative effectiveness research. But what we're arguing in our review is that, yes, there are definitely features in common with this kind of pragmatic research, especially research that involves complex interventions, but that the combination of features in whole systems research is really greater than it is greater than pragmatic research per se. That there are things in this field that are distinct, in particular the way of addressing dual diagnosis in some systems, and the fact that there are often a combination of features that show up together in whole systems research studies, such as the individualized, multimodal, behavioral types of interventions that are common in this field. And so we would argue that whole systems research is really a distinctive field that could benefit from greater work to bring researchers together, to train a new generation of clinician scientists in model valid methodologies. And I say clinician scientists because there is really a distinct role for practitioners to be involved in whole systems research. And this is something that I talk about a lot in with students in my research courses, because what is really distinct about whole systems research, I think, is the way in which the interventions that are trialed in these studies reflect practice on the ground. real-world practice. And unless those who are designing studies are familiar with the paradigms from which these interventions come, it's very difficult to design a trial that really reflects real-world practice. And so finally, there is definitely room to develop the field in terms of how to do statistical analyses of how the multimodal character of the study is really behaving, right? So what, in terms of what's doing what and how. And of course, there's also bigger questions in terms of what types of measurables that we're not necessarily measuring are perhaps relevant. Something that comes to mind are issues around ecological impacts of particular therapies, accessibility of certain therapies, and I think it starts to raise much bigger issues in terms of what type of research belongs as part of the clinical research world. But I will leave it at that so that we do have a couple of minutes for questions, and thank you so much.
Well, thank you so much, Nadine. I'm going to turn it over now to Bo. Bo, I can read the questions that are coming up in the question box if you would like that. And Kieran had a couple of questions in the chat. Let me know if you're able to see that or you need me to read them or would like me to read them to you.
Okay, I do see the questions. I'm just going to read them now. So Kieran, you're asking if and how the studies presented themselves, re-navigating positionality or inherent differences or perceived bias. Okay, that's an interesting question. I think most of, if not all of the studies do not explicitly address this issue. They're really identifying their methods, and in line with I think the convention in biomedical clinical trials are presenting the work as objective. And I think that's an important thing to do when we're doing quantitative research in particular, is to identify the methods and, identify limitations, of course, and potential, potential biases in the study. But I think that question of positionality is really one for the umbrella, really one for us to think about when we're taking a step back from research and just recognizing that the classical RCT it represents a particular way of seeing what's important in a clinical outcome or in a clinical design, right? And so it's not necessarily something that I think should be directly written about in a study per se, but something I think as researchers is worth talking about. And the second part here is, or does this relate to you finding a higher number of pragmatic comparative effectiveness studies? So the large number of pragmatic comparative effectiveness studies really, on one hand, related to the studies that were referred to us by our team of experts consulted for the study. I think that is probably the major factor there. And then this last question, or second one, has to do with, I was curious if any studies assessed looked to understand participant affinity to the paradigm. Yes, there were definitely studies, in particular those where patients self-selected which group they would join, which treatment group they might join, where this was addressed. And it certainly is a confounder in terms of evaluating outcomes. For example, there were a couple of anthroposophic studies we looked at that were coming out of Germany where patients were self-selecting into anthroposophic care versus conventional biomedical care. And again, there may, in those types of studies, be demographic differences that are impacting people's preferences, which raises a lot of questions in terms of how we determine, really, how we parse out outcomes. So these are definitely methodological questions. Okay, so there's a question around paradigms.
Nadine, Bo Anderson will moderate in the few minutes we have left, so you don't have to worry about reading the chats. Bo, let me know if you need any assistance from us to read the chats or if you can see the questions. Bo might be muted. Let's see. So, Bo, let us know. Yeah, you should be able to speak now.
Right. Can you hear me now?
Yes, we can.
Okay, great. Thanks, Nadine, for a fantastic presentation. I only saw one question from Kieran and then the one that I just added, but are there other questions from others?
There are a few questions that have come up in the question box.
Okay, let me see.
Yeah, they're from Andrew Vargo.
Yeah, I'm not seeing those.
We seem to have some technical difficulty with the question boxes, but we've got more than we can actually answer right now, so I will ask Nadine after the webinar these questions and see if we can get back to folks on them. Bo, did you have something that you wanted to ask in the 1 minute we have left?
Sure. So my question, Nadine, was you talked about paradigm-specific outcome measures. And whilst I think that's a great idea, the thing that kind of crossed my mind is it's quite well known amongst Chinese medicine practitioners that if you got a panel of 10 practitioners, they would come to different conclusions about the diagnosis of a patient, and therefore if they were assessing the patient on an ongoing basis throughout some type of a study, they would likely reach different kind of conclusions about the patient's condition. So to me, that would make the paradigm-specific outcome measures complicated.
Yes, it definitely is complicated. And I think it's only exactly as complicated as dual diagnosis in the study design. So the same issues that come up in terms of inter-rater reliability would have to be addressed in a similar way. And I know there is growing literature that addresses how to handle in a single study how different practitioners may use the diagnostic parameters differently. And this can be trained, and this has been documented. And actually some of the studies we evaluated specifically addressed or described the ways in which they themselves were working towards inter-rater reliability to make sure that the different clinicians in the study were being relatively consistent in their assessment. So this is, I think, this is the literature that I think needs to be further developed, but it definitely is not something that has no solution.
Oh, great, yeah. So another layer of sort of complexity to these types of studies.
That's right.
Well, we unfortunately are out of time. Some great questions came up in the question box, so I will ask Nadine following the webinar if we can get them answered. Keep your eye out on our website. We'll have the recording posted along with some supplementary materials. And just want to say thank you so much, Nadine, for the great presentation and giving us the background leading up into it, and to Kieran for your introduction, and Bo for the moderation. Sorry it was short. We'll have to make sure that we leave a little bit more time next time, and we will work out any bugs we have in the question box so we can all see them. So thank you all. This has been great. It went by too fast, and we look forward to getting this up on our website. Thank you so much again, Nadine. Really appreciate it.
Thank you so much.
Thanks, Nadine.